Okay, wonderful. And then if everyone could just please make sure they're muted upon entry, that would be great, so we can avoid any noises. And before we jump into Dr. Baldwin's distinguished lecture, we did want to take a few minutes to share about the American Lung Cancer Screening Initiative, or ALSI for short. We'll then have the privilege of hearing from Dr. Baldwin. Dr. Baldwin will give a 30-minute talk on his work in lung cancer screening, followed by a fireside chat where anyone in the audience will be able to ask questions. And so before we hear from Dr. Baldwin, I'd like to invite Priyanka, ALSI's wonderful executive director, to provide a brief update on what ALSI has been working on.
Thank you, Alex. ALSI is a national 501c3 nonprofit, and our primary goals are to raise awareness of lung cancer screening and help high-risk individuals get screened. To date, ALSI has hosted over 460 grassroots community events at libraries, health fairs, farmers markets, churches, schools, and many other locations, educating over 20,000 individuals about lung cancer screening. ALSI currently has 48 college chapters, with students leading awareness efforts in their respective local communities and hosting events weekly. We have worked with over 450 governors and mayors from 50 US states and Canada to issue proclamations recognizing November as National Lung Cancer Awareness Month and recognizing the importance of lung cancer screening. We have also worked with over 85 mayors, members of Congress, governors, and physicians to create short public service announcements, or PSAs, raising awareness about screening and encouraging high-risk members of their community to get screened. For November Lung Cancer Awareness Month, our team launched the first ever National White Ribbon Relay in collaboration with the White Ribbon Project. As a symbol of unity and love within the lung cancer community, 5 white ribbons have been making their way through our college chapters and will finally meet Heidi and Pierre in Denver, Colorado, filled with their team signatures. Currently, our white ribbons have traveled through 24 ALSI chapters and 9 US states. In 2020, ALSI first worked with the US Senate to pass Resolution 780, which recognizes November as National Lung Cancer Awareness Month and expresses support for the early detection of lung cancer. 2020 marked the first time the US Senate has ever recognized the importance of lung cancer screening. ALSI has worked with the US Senate to pass a resolution every year since, including this past year in 2023. We have many other initiatives ongoing to increase awareness of lung cancer and lung cancer screening. Our Not Just a Statistic project, led by Natalie Wing, provides a platform for anyone affected by lung cancer to share their experience or the experience of a loved one. The project aims to inspire and motivate others to increase awareness of lung cancer in their communities. The stories shared as part of the Not Just a Statistic project are displayed at community centers and libraries across the US. Additionally, ALSI hosts a podcast series called the ALSI Podcast, with the goal of sharing the stories and experiences of patients with lung cancer and caregivers, as well as the work of doctors and researchers in the field. If you're interested in learning more about our work or would like to get involved, please visit our website at www.alcsi.org. Now I have the honor of introducing our esteemed guest, Dr. Baldwin. Dr. Baldwin is an honorary professor in the School of Medicine at the University of Nottingham, the leading respiratory physician on the UKCT lung cancer screening trial, the lead clinician for lung cancer, National Health Services England, and he's also the principal investigator of the Sputnik and Sarbooth trials, chair of the UK Clinical Expert Group for Lung Cancer and Mesothelioma, as well as an advisor to the UK National Screening Committee. We're so honored to have Dr. Baldwin here today to share his invaluable insight and expertise. And during his presentation, we encourage everyone to think of questions to ask Dr. Baldwin in the Q&A session that will immediately follow. And with that, I am pleased to welcome and hand the mic off to Dr. Baldwin.
Okay, well, I'd just like to say that the honours sort of all mine, really. This is just amazing to see what you're doing, and this just in awe of what you're achieving, actually. As I am with a lot of people that are in this whole area in the screening, which I'll try and get over to you. So I'm going to talk about 30 minutes as instructed. I've got a few conflict of interest there. There's not very many, but just so that you're aware, I've advised the UK National Screening Committee that, as said, I'm involved in a number of quite big artificial intelligence studies as well. But I don't think any of this is going to affect what I'm saying today. What I'm going to do is to try to cover some of the basics of cancer screening, some of which may well be familiar. Apologies to that, but at least it'll be a recap. And then I'm going to review the evidence for effectiveness. I'm going to talk about then what the next steps are, which are optimizing screening and what work people have done in this area. And then I'm going to talk a little bit about the UK and what we've managed to achieve in the UK, what a lot of other people have managed to achieve in the UK, and then talk about what's happening right now globally and what's next. So just to go back a step, first of all, the first screening studies for lung cancer occurred in the 1950s with mostly chest x-rays, and they were mainly observational cohort studies. And then people realized that you needed to do randomized controlled trials. So they did a whole lot of randomized controlled trials. This is just 4 of them, the larger ones. And interestingly, these studies showed quite a marked difference in the 5-year survival, which was the primary outcome, such that if you did chest x-rays every 4 to 6 months versus a chest x-ray every a year or so, you had a difference in survival that was between 33 versus 15% or 35 versus 15%. So you can see quite a marked difference in survival. But the problem was when later on they looked at the number of people that died in each of the groups, they actually found that if anything, the people that had the screening had more often patients died in that group. So it actually looked as if it was harmful, which is what this graph shows here. So that's because of the difference in the 2 measures, the death rate, the mortality rate, and the survival rate. The mortality rate is the number of people who die every year of a given cause, usually in a specific population, often defined per 100,000 people. Whereas the survival rate is how many people are still alive at a specific time. And the key thing is after diagnosis. So it's a time interval that you're measuring here as opposed to a rate and proportion of people. And the reason that we have this discrepancy between survival and mortality is now known. At the time, it wasn't really known very well. But the first thing that you've heard about is something called lead time bias, which I'm going to just introduce you to this method of showing this, because I'm going to go through some other biases in a moment as well. So we've got a timeline, first of all, and we have a control group that haven't had any screening. And just for argument's sake, we have 5 people there, 1 of whom has a lung cancer. They get symptoms, they get a diagnosis confirmed, and unfortunately die of the condition. And the time from diagnosis to the death there is survival time. Now, if you take a screened group, this time the cancer is diagnosed earlier. The patient dies at the same time, and the survival time is much longer. And the difference between the 2 survival times is the lead time. So this is a relatively straightforward thing to understand. If you diagnose earlier, you're going to survive longer. And that was one of the biases operating in these studies. And then the other one, and this is probably the most important bias, is called length time bias. And this is actually the reason that screening works, in fact, which I'll explain a bit later. But the concept is that you have aggressive tumors that have a very short onset, then they become detectable very quickly and they get symptoms very quickly. And these people often also die very quickly, sadly, right the way down to the indolent cancers where it's all much slower. And again, we have this timeline here. You've got a lot of indolent cancers at the top there, a lot of intermediate ones, and a lot of very aggressive ones. If you throw in a couple of screens, not surprisingly, you pick up more of the more indolent cancers, the ones that aren't growing so fast, because you've got a longer time to detect them. And in fact, in this particular example here, we've missed all of the very aggressive cancers because they presented between screens. So naturally, screening is going to pick up more indolent cancers, and that is a good thing in a sense because it picks up more cancers that are much more curable. And the downside could be the next thing, which is called overdiagnosis bias. Now here in the screen group at the top here, you can see that there are 3 cancers in the group. 3 were diagnosed by screening, only 1 died, and the others then died a natural death. But it looks as if we've managed to prevent 2 of the 3 dying from cancer. But in actual fact, if you looked at the control group, which is the scenario where the same group would not be screened, then only 1 of them gets symptoms, only 1 of them gets a diagnosis, dies at the same point, and the other 2 would never have had the cancer at all. And that's what overdiagnosis is. It's basically diagnosing cancer that would never have any impact on your morbidity or mortality. And this is quite an important concern, particularly in some of the screening programs, notably the breast cancer screening program. It's an extreme form of length time bias. And what we want to do is detect cancers that will, in the end, shorten the person's life expectancy, but you can cure them because they're less likely to metastasize and be difficult to treat. So that's the way screening works, quite an important concept. Now, moving on to some of the evidence now, we have two large randomized controlled trials that have now been published. The first one was from the US, which was the largest trial and still is the largest trial, randomizing 53,452 people. And what they did was to screen at time 0, time 1, and time 2 with low-dose CT scanning, or in the control group, chest X-ray. They stopped the study 1 year early because of the stop criteria being met, which was a 20% reduction in mortality, a 20% difference in mortality. And sure enough, really impressive results. We had to wait another 10 years before a much smaller study was published from the Netherlands, which is called the Nelson trial. And here we saw over a 5.5-year period of screening, which is here. They screened at 0, 1, 3, and 5.5 years, mainly in men. This originally was just men. We saw a 24% reduction in men and a 33 to 44% reduction in women. So a very impressive, both of these trials, very, very impressive. Now, I'll tell you in a moment just how impressive they are and why I was so convinced once I saw the results of the NLST trial in particular. But we've also got a lot of the data since then of on mortality. This is one meta-analysis that we conducted, which showed an overall 16% reduction in mortality, lung cancer mortality. And the reason that's dropped so much is because we used the very latest results for the NLST. And in fact, that's probably pretty unfair because by that stage, you got a lot of dilution effect from waiting too long. This was probably a better one, which was the recent Cochrane review, which showed in Europe a reduction in mortality of 22%, and in the US, because it's only one study there, 20%, overall 21% reduction in mortality, lung cancer mortality. But what's unusual about lung cancer screening is it also shows an all-cause mortality benefit, here measured in the Cochrane review of 5% and by us at about 3%. And very importantly, this is not shown in any of the breast or colorectal screening trial meta-analyses. That's because more people die from lung cancer, so you've got a bigger signal. And it's a really big deal, all-cause mortality, because what you're doing in this population, you're extending the participants' life expectancy. And anyone that knows anything about public health it knows that it's really difficult to extend people's life expectancy with all sorts of different types of intervention. Even the great progress we've shown in cardiovascular mortality only increases life expectancy or all-cause mortality by about 5%. So you can see this is very, very important indeed and a really novel aspect of lung cancer screening. And we also know that the mortality reduction is probably much better for women. I mean, a lot of the things that you see in epidemiology, if you study epidemiology, is that women always do better. They always live longer. Whatever you look at, apart from female diseases, they always do better because they're just generally healthier and more robust in old age. But you can see 8% versus 27% in the NLST and 24% versus 40 to 50% in Nelson. And in fact, at year 8, there was a 59% reduction in mortality from lung cancer in the Nelson trial. The all-cause mortality tends to benefit people that smoke more than ex-smokers. That's purely because there are more deaths from lung cancer in smokers compared to ex-smokers. So the all-cause mortality benefit is higher. And it's important to note that this is the only intervention that is noted that has actually been proven to substantially reduce deaths from lung cancer, except of course smoking cessation, which massively reduces deaths from lung cancer. So it's very, very important intervention. So pushing this very hard and making people aware, which is what this group is doing, is so important. And the evidence seems to be that modern treatment is improving this further. So we get better survival from early stage disease compared to late stage disease with the newer treatments. So I said earlier, didn't I, that the NLST was very convincing. Well, one of the reasons I found it so convincing once I got to grips with what they'd done was because it wasn't actually very perfect in terms of its design. It screened a lot of people at low risk who really wouldn't have benefited at all. There was a lot of over-referral of nodules to clinical teams because we didn't really know how to manage nodules as well then. Had a high level of investigations and surgery for people that didn't turn out to have cancer. About a quarter of them had that. They didn't use modern nodule evaluation techniques because they weren't around when the study was designed. And of course, they used chest X-ray as a control arm, which at 6 years seemed to show some slight benefit compared to an equivalent group in another related study in America. And also they only screen for 2 years because this is what you do in screening trials, so you can measure over diagnosis, etc. So it was actually relatively limited. So there's one thing. And actually, when I talked to the principal investigators about the study design, they said actually they designed it to show that screening for lung cancer did not work. So that was really convincing for me. And we can optimize. And what about Nelson? Is medium-sized beautiful? Is the Nelson optimal? Well, no, it isn't, because the Nelson investigators themselves showed that the last screen, which was 2.5 years after the one before that, the penultimate screen, they showed a higher rate of interval cancers, showing that the screen interval was too long. They also screened mainly men that had relatively poor outcome. There was no fixed downstream workup strategy, and they had a high level of investigations and surgery for benign disease. So we can do better. And that brings me on to the next section of the talk, which is optimizing screening for lung cancer. So this means effectively we're trying to maximize the benefits and minimize the harms. And the benefits that I've listed here: early stage detection, effective, safe treatment, incorporating smoking cessation, making sure everything is done quickly because lung cancer does progress quite quickly, limiting the intervention to those that will benefit and not bothering those people that have had low chance of benefiting, and then maybe other disease detection. And then the harms are all about false negatives, overdiagnosis, harms from workup and treatment, particularly in people that turn out to have benign conditions, and then from incidental findings, which could also represent overdiagnosis and overinvestigations, and also the psychological impact, which can be quite significant. I think this is all underpinned by adherence to evidence-based guidelines, nodule management, clinical workup, smoking cessation, and for incidental findings, which I'll show you very briefly what's happened in this space. This is a sort of summary picture of what we've dealt with since the publication of the NLST. We've worked very hard on all of these aspects, which lead to clinical and cost effectiveness. So firstly, selecting the right people, participation in the program, making sure that's maximized. That's a lot of what your organization is doing. Making sure the scanning process is optimal, managing the nodules, managing the other things that are found on the scan effectively, making sure clinical workup is safe and effective, and then finally giving people the best treatment. Smoking cessation integration is absolutely central. I'm not sure really whether we should be adding on spirometry and other things. That research needs to be done on that. We have to make sure patients are fully informed about the decision to go for screening. And finally, in many countries, capacity is a problem. So I'm just going to deal very briefly with 1 or 2 areas which I think are potentially slightly controversial, aka the UK and the US differ on the way we do things. So it's just a sort of get people thinking. So the first thing is selection. So there are 2 ways in which people are selected for screening programs that is currently used. The first method that was done in the NLST and the Nelson trial was to use just age and smoking criteria to define who gets into the program. The second method is to use multivariable mathematical prediction models. The simple criteria are usually something like the NLST criteria or the US PSDF criteria shown here, the pack years of smoking, the duration with which the patient has quit smoking, and the age range. They're simple to apply, but they do unfortunately select quite a lot of people at low risk who may not benefit. And then the other approach is something like the prostate, lung, colorectal, and ovarian model, which is more complex to use, but it does seem to more accurately define individual risk. But there is some concern that they might select people at high risk of death from other causes. And this led the American College of Chest Physicians to specifically state that risk prediction models were not to be used for entry into screening programs. This is, of course, is contested by others, especially the individuals that developed the risk prediction models. So just to illustrate the problem with NLST here, so if you can see the lowest quintile of risk here in this table had a really high number needed to screen to detect a cancer, as opposed to the higher risk levels. And when a modeling study has been done versus the multivariable model, we found that, or they found that there were more people would have been screened who developed lung cancer, and 41% fewer people were missed who developed lung cancer, which equated to about 12 more deaths prevented. Not very much, but certainly something to think about. And this question of whether models select less healthy people, this was a study published by the author of the PLCO model. And what he did was to take out that lower risk quintile of the NLST and look to see what their average age was. So here we have the NLST in green minus the low risk, the NLST in blue, full cohort, and the people that would have been selected by the PLCO model. As you can see, they're just slightly older. The morbidity count is slightly more than the limited data set, and quite a lot more than the full NLST data set, and likewise the cause of death. So there is some indication that these models do select people that are more likely to die of other causes. But whether it's enough to stop using them is a bit of a debate, and that's where the controversy lies. So currently we in the UK are using 2 multivariable models for our program. I think the Canadians are using their multivariable model. Most other countries are using pack year and smoking history to get people into the program. So the next area, which is controversial, not because we do things differently, but just because it's a real problem. And in the US, where we have most experience of participation rates, because you've been screening for such a long time, this is highly variable, highly variable. And some of the work that we did originally in the UK showed really poor participation rates if you approach on a population level. So this study was designed specifically to look at maximizing participation rates. And the aim of this study, the lung screen uptake trial, which I was closely involved with, was to test 2 types of invitation material, one tailored to the individual demographic, and this was an extremely deprived area of London, and the other more generic based on the existing cancer screening programs information. And we identified people from the primary care records, and they were invited as if by their GP. So the invite came from the GP. We were using techniques which had been shown to maximize participation in other screening programs, which included pre-invitation letters plus a leaflet, an invitation letter plus a leaflet, a pre-scheduled appointment and reminders, followed by repeat appointment scheduled if people did not attend. The intervention leaflet was designed to minimize fear, fatalism, stigma, and provide a really low burden level of information prior to the appointment. And the control leaflet, as I said, was based on the NHS cancer screening programs. And the overall participation in this study, because it was, of course, a study, was about 53% in both groups. So the clever material that had been designed didn't actually make any difference. And 73% of participants went into the scan, but that was mainly they were excluded because of other issues that excluded them from the program, such as risk, etc. So radiology, again, an area where there is a bit of a difference and maybe a bit of controversy. So we'd all say that we need to use the lowest radiation dose possible. We don't all agree whether there should be a dual read. Mostly we agree that there should be computer-aided detection used because it shortens the reporting time, and most people are very skeptical about radiographers reading CT scans as opposed to the way mammograms are read, for example. And then the other big controversy area is whether one should use volumetry, which is where we use artificial intelligence developed software, which will automatically or semi-automatically detect a nodule and measure the volume of the nodule. Now, there's no doubt that volume better predicts malignancy, and it is better at quantification of growth, and therefore avoids the potential for overdiagnosis. But it's time consuming. Admittedly, the software is getting better now, so it's much more automated. And when I was involved, I was one of the leads on the British Thoracic Society pulmonary nodule guidance, and we were so convinced by the evidence that we mandated volumetry as the preferred way to measure pulmonary nodules. And that was absolutely the first guideline that had mandated that. And we really did start using it in routine incidentally detected nodules from 2015 onwards. And so we're pretty convinced that volumetry is the way forward. Less so, I think, in the US, where the lung RADS process, which is used to manage nodules in screening programs, is mainly diameter based. It does have volume measurements on there, but they're just calculated from the volume of a sphere calculation. And I think the real issue is the time that it takes to do the volumetry, and we've got around that with a variety of different methods. And as I say, a lot of the automated methods now make that a lot more possible for people. So that's another area of controversy or difference. The other thing about screening is the interval. The screening program in the US is an annual program, and that is borne out by most of the modeling studies I've seen, which is whatever scenario you use, the annual in brown here is closest to the efficiency frontier when you're looking at discounted life years gains versus the cost. And most of the scenarios show that annual screening is more cost effective, but it is more expensive overall, and it does demand more capacity in the system. However, stratified programs are something we could use. A stratified program is where you stratify either the modality of treatment or the frequency of the treatment according to features of the individual. And in this case, it would be risk of lung cancer. This is data from the NLST showing that if you have a negative baseline scan, you're more likely to get lung cancer in the subsequent years. And exactly the same was found in the Nelson study, where a baseline scan that showed nodules indicated a greater risk of cancer, and it wasn't always in the nodules that you detected. In half of the cases, it was a fresh nodule. So it's a risk factor for ongoing risk of cancer. And we now have more sophisticated techniques to look at incorporate the findings of the scan to predict risk in the future. And hopefully this will give us a more sophisticated way of stratifying the program. So the other area which I think requires a little bit of discussion is the better prediction of malignancy by protocoled optimal workup. So a lot of the screening programs and studies, the secondary care process is relatively ungoverned, and people just do what they would normally do, which can be highly variable. But we want to try and improve things by reducing the traumatic investigations and approaches, and this means improving localization nodules, etc., and making sure we risk assess them. We've seen quite a big difference in the physical harms in the workup and treatment from the different studies. The UK lung cancer screening trial and LCAT both have quite low resection rates for benign disease. And in fact, when we've looked at the UK pilots, and I'll show you in a second, it goes down to about 2%. So that reflects, we think, the BTS nodule guidance that we're using. And also there's less use of additional diagnostic CTs in some of the studies compared to others, which again is a potential harm. So overall, we've tried to go through the various elements of optimizing CT screening. Smoking cessation is absolutely central. The Yorkshire Enhanced Stop Smoking trial uses a co-located opt-out smoking cessation service. What that means is the smoking room here in pink is where the smoking cessation advisor sits, and the patient goes from the clinic room, having had their risk assessment confirmed, into the smoking cessation room unless they specifically say they do not want to do that. So you get 88% of people that meet the smoking cessation practitioner, And the confirmed quit rate was 31% in that group of people. So a really important quit rate in smokers. And the key thing is making sure that you've got really good smoking cessation services. We have real problems with implementation, and globally there are problems with implementation because of the issue primarily of resources, which includes equipment and also the people that do the screening. We also have to ensure that the shared decision-making process, and many people believe that the system in the US, which is quite onerous, could be reducing participation rates. So I'm just going to very briefly go through the steps to a program and show you very briefly what the UK have done. So we start off with the research trials. We then go to pilot sites that show that expert and enthusiastic teams can match the trial results. We then have a really big test, which is the pilot program start, where we're going to places where people aren't particularly expert, they're not particularly interested in doing this, and it's extra work and it competes with other work. We've got to show the same things there. And then the full program is a matter of capacity planning, which is what where we are in the UK at the moment. UK lung cancer screening trial showed a 2.1% lung cancer detection rate. It showed a better stage distribution than was found in NLST, high resection rates, and with low harm rate. We had these 4 pilots that were run, and they all showed very similar cancer detection rates and early stage rates. So that was very encouraging. We also had a very low harm rate, as I explained, with including the UKLS data, a 4.6% benign resection rate and only 2% if you took that out, and no harms other than the benign surgeries in the people with benign disease. This is very encouraging. So the targeted lung health check, as it's called in the UK, was started, and it is a stratified program. It starts in people aged 55 to 74. They have a lung health check, which is now done by the telephone, and spirometry is not normally done. Smoking cessation advice. If they're low risk, they are referred maybe back to their GP if they have significant other diseases, but mostly they don't get referred. High risk are offered a low dose CT. If the outcome is suspected lung cancer, they go to a clinic. If the nodule, I won't go into this in detail, but there are various nodule criteria which either link them into a 12-month CT scan, followed by a 24-month scan, or straight into a 24-month scan here, as you can see at the bottom. So it's a stratified program according to risk, which is defined by the nodule presence. It's now active in 43 sites, and more sites are being taken on as we've received approval to go ahead. As of September, there are 1.2 million invites sent out and a total number of 305,000 scans. The number of lung cancers detected is shown there at over 2,800, and the early stage rate, stage 1 and 2 rate, is 76%. As you can see, the program didn't really take off until about April 2021 and was pretty much suspended during COVID. So really the big impact has started from 2021, and that leads into the next slide, whereby we can see that the cancers detected has now risen above the pre-pandemic levels in the UK. And this isn't just the screening cancers, this is the total rapid cancer registration data set. So it's all lung cancers. It shows the massive impact of a program that is still only around about 20% coverage. And this is another massive impact of the program. So this shows for all cancers, on the y-axis, the proportion of people that are at stage 1 and 2, early stage cancers. And each line represents the quintile of deprivation, with the most deprived people at the bottom and the least deprived at the top. This is for all cancers. And this is lung cancer. In red and yellow are the lowest, in red is the lowest quintile, yellow is actually the third quintile. But if you look at the red here, by the time the program really started off in June 2021, you can see that the early stage detection rate went from the bottom to the top in lung cancer. And this is all lung cancers again, which is really quite a big signal, really, because the reason this happened, of course, is because we targeted the very high incidence areas for lung cancer, and they tend to be the ones where there's most deprivation. So the really big impact, and something that really does convince people that this is a very good thing to do indeed. So what next? Well, next is European implementation. There are lots of national programs that are going on in Europe. There are a number of European documents now that have been written, which are good guidance documents for the European countries. And there is in the European Beating Cancer Plan a recommendation to start lung cancer screening in a phased way according to capacity considerations. But it also recommends prostate screening and some upper GI screening, which is doesn't have the same level of evidence. If you want to see what's going on globally, then see this Lung Cancer Policy Network map, which you can zoom into and find all the programs that have been registered on this interactive map, which is really very useful. Lots is going on. So I'm just about 30 minutes now. So take-home messages for lung cancer screening that I'd like you to go away with are that lung cancer screening, low-dose CT screening for lung cancer needs to have an equal standing with other cancer screening programs because it's at least as effective. Careful adherence to protocols, ongoing evaluation and further improvement is absolutely essential if we're to optimize the programs and maximize the difference between the benefit and the harms. In some countries, unfortunately, capacity is going to be a key barrier. And certainly in the UK, it is defining how quickly we can cover the whole population. But it needs forward planning for workforce. It needs state-of-the-art equipment and facilities, including any innovations that could be used. So I'll stop there. I haven't covered cost effectiveness, but any other comments that you want to make and any questions, I'm happy to answer at this point.
Wonderful. Thank you so much, Dr. Baldwin, for that excellent presentation. And we'll now transition to the Q&A portion of the lecture. I do see our audience. I just want to highlight that it includes a wide range of people from undergraduate students to patients with lung cancer, to friends and family members, and to experts in the field, including Dr. Chris Berg, who's the PI of the NLST. So we have a great audience. And we'll open the floor for any questions that people have. We do prefer that people ask them verbally if you're comfortable with that. If you're not comfortable with that, please feel free to put them in the chat. That will work as well, and we can read them out loud. And I can start us off with a question, and then we can please feel free to speak up. So just again, it was a fantastic lecture, Dr. Baldwin, and thank you so much for your time. And one of the things that really struck me was your discussion of the National Lung Screening Trial. And at least right now in the US, a lot of our shared decision-making tools are based off of the findings of the NLST. And as you noted, since the NLST, there have been significant advancements in nodule management. The NLST also screened people for up to 3 years and then followed them. So you also noted there might be some dilution of results, and so, or of the benefits of screening. And so I suppose one concern is that shared decision-making tools based on the findings of the NLST may underestimate the benefits of screening and may actually overestimate some of the harms that we've now been able to address. And this could potentially dissuade maybe some hospital systems from fully supporting screening, and may also dissuade patients from getting screened if they're seeing these facts. And so my question was, what's the best way that we can encourage people to develop shared decision-making tools that accurately portray the present benefits and harms of screening? And I just wanted to really highlight your trial. It's impressive how low a lot of the harms you showed were in the, I just think very impressive. So yeah, that's my question.
Well, it's a really difficult question. So well done. And there's a lot of debate on this. And there are two schools, I think, as I see them, two schools of people that will publish on this and provide advice. And there's the sort of purist school where they want to be really careful to explain to an individual the chance of detecting a cancer, but also the chance of preventing the death, which is two very different things. And of course, the way we measure the impact of screening is we measure the prevention of death. So it is technically absolutely the right way to do things. But as an individual person and a patient, when you talk to patients themselves, and of course you'll be talking to lots and lots of people, that's not really, doesn't really resonate very well with most of them. So if you try to get that over in, say, at a stadium chart or something, which is what a lot of people have done, where you've got all the people screened, and the people that have the cancer, and then the people that are prevented in death, it looks pretty unimpressive, especially if you use the current NLST figures. And as you pointed out, NLST was a study that was designed to show how screening worked, including being able to measure overdiagnosis and all the rest of it. And as a study, it has contributed to so many other studies because of the way they'd made the data available. And there are so many sub-studies. We looked at this some time ago, and we looked at this NST. It was one of the most used studies in terms of other studies to actually generate further data and further knowledge. So it's been incredible. But as it's not a program, and we don't. It's really difficult to estimate the numbers that of death prevented in a program. And certainly the Nelson people have done some of this modeling and shown if you run a full program for the life expectancy of the patient, then the chances of preventing death are far greater. So I do think you've got a point there. And I think that personally think that any of the shared decision-making process that are based just on the NLST results have to make it really clear to the person that this is based on a program that just screened for three screens over 2 years and then stopped. And that's absolutely not what you would do as a person. You would stay in the program and you would accrue the benefit as you get older. And so there is, it's really difficult, this is. So I haven't got any answers to this. The other side of the coin is to say, well, look, you detect a cancer early and your survival is so much better. So we're using the wrong metric, using survival. But for the patient, it says, oh, right, yeah, I have the cancer detected at stage 1, of which, 70% of do versus 30%, then I'm going to survive all those extra years. So you're sort of misleading the patient, but it's something that resonates with them better. So I don't know what the answer to this is. I think you have to present all of the data and you have to make it clear that you're explaining about a program rather than a trial. And certainly our own information that we're designing is a sort of hybrid approach of both. So I don't think that's necessarily the best thing either. I'm not saying it is. So no answers. Difficult question. Very good one. No answer. I'm sure Chris and other people on the line might be able to fill us in a bit more.
Okay, well, wonderful. Thank you so much for your response. I really appreciate it. And I know Dr. Stutz is next in line. I did want to see if Dr. Berg, if you had anything to add on to that discussion before we go on to Dr. Stutz, or are you able? Oh, sorry, let me allow you to unmute. Go ahead. Yeah, you should be able to now.
Yeah. Okay. Well, thank you very much for calling on me next. And I apologize, Jamie, for jumping the queue. And first, let me congratulate Dr. Baldwin on his outstanding lecture. I found it very informative and I really enjoyed it. And I liked Alex's question. I do have a few comments. One, the NLST was designed to really only answer the question of did lung cancer screening with low-dose CT lower lung cancer specific mortality. We did not answer questions about optimal management of nodules. We really felt we had to really aggressively evaluate the nodules if we were going to maximize potential mortality benefit. We didn't want to have a negative study just because we didn't evaluate the nodules aggressively enough. However, we reported our results in November 2010, and it's been 13 and a half years almost. And I think the work that people like Dr. Baldwin and Dr. Yang and the other groups have been doing is outstanding. And I do not think that informed decision making should be based upon the NLST. I think it was designed for a different kind of purpose. And so I liked your question, Alex, and I think we need to have more modern interpretations. I do, though, was very chagrined by a recent publication from I think it's the Prosper Group at the NCI that is assessing lung cancer screening programs in community situations that had higher morbidities from many surgical procedures and invasive pulmonary procedures than we had actually seen in the NLST. I do not want that paper or findings such like that to discourage lung cancer screening. I think what we should be doing is working with the pulmonologists and the thoracic surgeons to minimize the harms from these procedures. These procedures are not done just with lung cancer screening, but they're done in routine pulmonary and thoracic healthcare as well. And we need to, I would like to see the community programs improve their metrics and improve their with lower morbidity and mortality from these procedures. And I think under the excellent auspices of people like Dr. Yang and this group, you'll be achieving a lot of good things. So thank you for the opportunity to comment. And thank you again, Dr. Baldwin, for your great talk.
Thank you.
Thank you, Dr. Berry. That's very insightful commentary, and would love to turn over to Dr. Stutes.
Yes, Dr. Baldwin, thank you so much for such a measured and thorough presentation. It's really an elegant presentation of some of the pros and cons. I think sometimes, in my opinion, we're turning the shared decision-making into a boogeyman that is a very unfortunate strategy. Shared decision-making is to me, is a very person-centered approach to helping people engage this process. It is not a harm, it's actually an asset and a resource that we have to help people. I will get to my question in a second, because I think it helps build adherence to the algorithm. In the United States, we've spent so much time, energy, and effort in creating uptake that we've forgotten that adherence is what helps people benefit from lung cancer screening and engage that. And we've shown through some claims data that shared decision-making actually facilitates adherence to the long-term algorithm for those interval follow-ups, as well as the annual screenings, when we really change outcomes. That's when we really identify those early nodules, and that shared decision-making is a vital part of that. So my question for you is, we spend a lot of time focusing on uptake, but we really have the twin challenge of uptake and adherence, and really engaging this community of individuals that does not have the best relationship with our healthcare system. So what are some of the adherence signals that you're seeing in the UK and across the world? Because the US signal is atrocious. And we can't, with Gerard's data, Dr. Silvestri's data is showing, 22% adherence to annual screening. We cannot achieve the study outcomes in mortality reductions with a 22% adherence rate versus the 90+ in Nelson and LST. So that's a downside to presenting where actually the NLST and Nelson may be a much more positive outcome than we can actually achieve in community implementation.
Well, it's a really good. It's a very important question, and I would just say one thing about the US data. There are some pockets of really good practice in the US that have shown very high adherence rates, and they've used approaches like patient and nurse navigators that are so sort of connected to their community that they sort of almost provide a sort of patriarchal or matriarchal role, and I think that's very important. We're not currently doing that in the UK, but we do have some astonishing participation rates in the UK, which are not explained so far. So several things about a program. When you start to do a program that I'm learning, obviously you're already well ahead, but I'm learning a lot from the program because we see things you would never measure in a study. And one of the things we've seen, for example, at Newcastle and Gateshead, which is an ex-mining village in the northeast of England, and local to us in Mansfield and Ashfield, just north of Nottinghamshire, we had over 70% participation rates. Which was completely unexplained because very high deprivation areas, you'd expect a 35% participation rate or so. Overall, the program has a 41% participation rate. Now, in answer to your question, we don't know yet about the adherence rate, but so far, with the few additional scans that we're doing, all the participation, the adherence rate to the 1-year scan is really high. but these are people who've got nodules and they're worried about them. The key metric will be the adherence rate to the 2-year interval scan with people that don't have actionable nodules. And at the moment, it seems that people are coming back for their scans. And we've not got any official metrics on this yet, but it hasn't flagged as a signal yet that a lot of people are not attending. So one of the things that we do in our information to the patients is that every single contact we explain the fact that you get the maximum benefit by staying in the program, so that they should at least have the information. And there's a lot of activity. The research evidence suggests that all of the activities that you do to get maximum participation also work in adherence. So you should be doing even more effort in terms of adherence than to the participation, or at least as much. So that's what we're doing. No data yet, unfortunately, to present, but hopefully it'll be favorable when it comes through.
Wonderful. Thank you for the wonderful question and response. And then I'll turn it over to Dr. Chang for a question.
Hi, thank you so much for the amazing talk. It was so interesting and well put. I'm the thoracic oncology fellow who works with Leisha Sequist, who unfortunately has clinic this morning, and sends her apologies for not being able to be here. My question is about novel technologies in risk stratification and screening. It seems like underpinning a lot of this conversation about uptake and adherence is making sure that we consolidate our efforts in basically capturing and retaining patients who are at highest risk. But we're still in a place where identifying risk factors for lung cancer is challenging, especially for patients who don't have obvious extensive smoking history. And we know that there are so many risk factors out there that put patients at risk besides smoking. So I'm wondering if you can speak to some of the new technologies that are coming out, both for screening and risk stratification. Dr. Sequist and I have talked to a lot of interesting startups with detecting volatile organic compounds in urine or breath tests, and also using artificial intelligence to design image analysis algorithms to risk stratify patients, in addition to blood tests that are designed to either detect many cancers at once or are optimized for lung cancer. And I'm wondering what you see as the future in 10 years in terms of being able to identify patients who should be aggressively enrolled and retained in screening programs, and also potentially improving access to patients who aren't near CT scanners.
Well, a lot to cover there, but I'll try and go through it. So, I mean, so starting with the sort of basic approach, the conventional mathematical model, just taking in additional information from the CT. You know about the LD-CCRAT, which is the sort of mathematical model which takes into account the baseline screening. It shows slightly better prediction of future lung cancer risk. Is that way forward? I'm not sure. I don't think we're ready to adopt anything like that yet until we know more, because it's a big thing to then adopt something else after that. So I think we should wait. Breath tests so far haven't been very successful in this area, and I don't think in the screening setting they're going to be successful. Certainly, that's my interpretation, because they're not yet successful even in the symptomatic setting. Blood tests. Well, the issue with blood tests is what the blood sacs actually mean. And as you know, I'm sure you know this, but people don't know this, that if you've got either tumor cells or bits of tumor cells like DNA or RNA in your blood, then it confers an adverse prognosis. And the latest data shows that even with treatment, it's still a worse prognosis if you have a positive ctDNA. So as I explained earlier on, the sort of basic stuff about length time effect, you don't want to be detecting the aggressive cancers in screening unless you've got treatment that will stop them dying. And at the moment, we don't have that. We have treatment that will improve the survival at any particular time point. So that's where survival is a good measure. But it's not the same as actually curing someone, which is what we're aiming for with screening when you're screening a lot of asymptomatic people. So the blood tests at the moment I think it's a shame. There's an awful lot of these ctDNA tests which seem highly sensitive, but we need to understand what they mean before we start to use them. And then the other thing that I think is possibly a slightly positive thing is there's one blood test that doesn't actually work, in my opinion. It's called the OncoImmune test, or the early CDT. It's not sensitive enough. but there was a slight signal of reduced mortality in positive tests. And intuitively, if you've got an immune signal, which is mopping up your cancer cells, then it could be that that's a positive identifier for somebody who's going to do well. And I think a lot of the companies now are looking at the genomics and epigenomics of the immune reaction to see whether they can get a signal from that. So there's promise there. So coming back to the most promising thing is right in your area, which I think is AI. There's a lot of AI being applied to imaging at the moment. You would have thought that there was a limit to this in that you've only got so many voxels to play with, but it doesn't seem to be the case. It seems to be that there are some algorithms, particularly the Sybil algorithm, but there are others as well, probably not as good, that seem to be able to predict cancer. And we need to understand why that is. That would be much better than just knowing that it works. And we need to test them in external data sets, which is one of the things we want to do in Nottingham and try to access a large CT data set, which I'll be in touch with you about that. But the thing is, we need to affirm that they work. But if you're asking me the most promising at the moment, personally, having gone through all the other things, the thing that's showing a lot of promise is the AI techniques. But it could go the same way as, it could go the same as blood tests. We need to understand what it's doing and what it means. And I think that's a lot of people seem to think you've just got a detection test and that's it, but it isn't actually. And the blood tests are showing exactly that, that we really do need to understand this. And also the last thing is a lot of the people that do early diagnosis, the laboratory scientists, etc., aren't screeners. They don't understand screening. They don't understand the principles of screening. So that can be a bit of a weakness there. But an excellent question. I hope I've covered most of it, not all of it.
Thank you. And it was very meaty. Thank you.
Wonderful. And before we jump to the next question, I did want to highlight Dr. Kazaruni's just put into the chat that the most recent estimate of adherence to screening in the US is 39%, which is notably higher compared to the 22% reported in the original paper, but as Dr. Stutz noted, is considerably less than 90%. So I know we still have a ways to go, but I think important to highlight that there are improvements being made. And I do see Dr. Kashava has his hand raised. Dr. Tupper was unable to raise her hand, but has been waiting for a while, so we'll have her ask her question first, and then we'll go to our last few questions.
Hi, Dr. Baldwin. Thank you so much for such a great talk. I have a practical implementation question. When you're doing your pilot, you probably have pretty dedicated providers working in that setting. And meanwhile, the UK and the US, everywhere, there's really a shortage of primary care providers who do the majority of screening generally. In your pilot, do your practitioners need to reorder the scan, or is it automatic based on their previous results? And do you think there's any role for a standing order for the low-dose CT, like there's been for mammography, which has generally increased adherence?
Well, it's very different now because the pilot is now, the pilot was really a program. It was underneath I didn't go into the detail, but there's a very strict way in which we sanction screening programs in the UK. And we did go outside of that and then retrospectively then went through the process of approving it through the UK National Screening Committee. But actually the way it works, the first wave of pilots, they were feeling their way and understanding how it worked best. But we started in Nottingham as the phase 3, and I can tell you I had to do nothing at all. It all happened. They knew that the process was absolutely seamless. The administrators sorted out the mobile vans going into the different car parks around Nottinghamshire. All I knew was that the alerts came through to my email to say, this is a red alert, you need to look at this scan. And the scan was there on our system, all ready to go. So we could just look at previous images, etc. All the scans reported within 72 hours. It is astonishing and this is nothing to do with me. This is the people that have passion about screening and changing the local health of their community. And these are the type of people that actually work in the program. So we have a system whereby you are eligible for screening, you are consented into the program. The scan does not need to then be requested. It's part of the screening program. It's just like mammography is. And then everything else then happens digitally. And it's just astonishingly good. since COVID, with COVID, the program was paused, but they did a lot of it not remotely. So all the risk assessment is done over the telephone. Patients are phoned. 2 multivariable models are applied over the telephone, as well as other eligibility criteria. Then they're invited. That's when they get consented. Then they get the scan on the same day. So it's a very seamless process for us, and it works incredibly efficiently. And this is all down to the sort of the process that we've been going through of developing how it best works. I think when people first use a mobile van, they realize they've got to have a security system, because otherwise everything gets stolen off the van. For example, you need water supplies and all sorts of things. But this is all known now because people have done it already. And from our experience, that we had to do almost nothing as clinicians. We just had to set up the screening review meeting. In the UK, we have a screening review meeting where all the positive findings are reviewed at the screening review meeting, and management done. It reduces the amount of downstream activity. Does that sort of answer your question? I mean, it's very, very seamless, actually, very, very efficient.
But does somebody have to put in the order subsequently after they get their first screen, or does it automatically?
Oh yes, sorry. So yes, that's done by the screening program. So we have screening practitioners who will organise the next scan according to what the finding is, and also take the patient's offers up from the screening review meeting if we decide they just go back into the program. There are standardised letters for every single finding, and anything that's not standard, we will write an individual letter to the patient. Again, with that sort of please come along for your next scan sort of thing, that type of thing. So yeah, it's all, and you've got lots of standard pro formas. I mean, it's sort of thing that for other countries where they're not developing a program, it's really useful. They're taking our material and using it because it's quite an end-to-end process. But for the US, where you're already experiencing this, it's not probably some of the teaching grandmothers to suck eggs, etc.
Okay, thank you.
Wonderful. And I know we're at the hour, but I wanted to just have Dr. Kashaw, if he could ask his question. Yeah.
I'm okay. Anyway, I've just got a Spanish lesson in an hour's time.
Oh, perfect.
Yeah, mine will hopefully be a quick question. And thanks for this talk and for Alcy for putting this on. I'm one of the thoracic surgeons here at UC Irvine in Southern California. We have a couple of different issues here in California, especially Southern California. One is, I want to ask you about, how do you deal with the stigma behind lung cancer screening and it only being for smokers? And then 2, what do you do about the non-smokers? Most of my practice is actually non-smokers that get lung cancer, which is just because of our Asian population down here in Southern California. And what do you tell them? What do you tell their family members? Do you think there's something that we should be doing more about destigmatizing screening, and should we be screening these types of people?
So I think this is a constant battle, this stigma that really should be a thing of the past now, but it's there all the way through. And I'll give you a couple of examples, but just to deal with the never smokers. So if you're talking about never smokers, at the moment, we cannot justify screening never smokers because the incidence in the population that we're screening is too low. There's a lot of work going on in this area, whether there are subpopulations and individuals that could be identified and then it's something applied to them. It might be a genomics analysis, for example, which is being talked about, but it's definitely likely to be certain subgroups. And then you've got a problem with equality. So you start to say, well, this subgroup of, say, I don't know, South Asians or something, whatever population, and then somebody next door in the same time will complain, and that's a real public health issue in the UK. So we're struggling with this area. At the moment, we're able to say that never smokers, it's just not cost effective, and that's it, because cost effectiveness is the key thing. Now, with regards to the stigma, it is a constant problem. So, for example, the wording on the recommendation of the UK National Screening Committee says that offer low-dose CT screening to detect lung cancer in people 55 to 74 who have been determined to be at higher risk of the disease or high risk of lung cancer or something like that. That was the wording that I eventually managed to sort of really bash the committee with, because the proposal was offer screening to heavy smokers aged 55 to 74. I mean, how is that good? That's going to cause stigma, and that's the screening committee saying that. So people just don't seem to get that, if you label people like that, then it stigmatizes them straight away and it stops them participating. And the reason that my text went through rather than theirs was because I said this is going to stop people participating, and we're anticipating low participation rates. So we have to change this. So I mean, the answer to your question in terms of the never smokers is that I can't see any justification for that at the moment until we can manage to get a higher risk group, or come up with a screening test of some sort, which is much cheaper, like, you know, the FIT test or something, which will identify that you can then offer to all patients. And the issue is identifying areas where they've got a very high prevalence of disease like yours, and then saying, now we should do a pilot study of some sort to see what our detection rate would be if we offered similar people who are asymptomatic a low dose scan. And then you can then generate the data that would then be used to do that. But at the moment, I'm afraid we can't really do that until we have other markers that could be the case. I mean, the programs like the AI programs, it may be that people have had a CT scan for something else, and the algorithm says this person's got a higher risk of lung cancer. So you put them into a screening program from it. That's something for the future. But certainly at the moment, I'm afraid never smokers, we can't justify screening them.
Wonderful. Well, thank you so much for the terrific Q&A and discussion. And before we leave, we want to get a picture of everyone. And so Priyanka is going to take it. If you're comfortable in doing so, please keep your video on or turn it on. If not, that's totally fine. And then I'll count to 5 and then say smile. And if you could please smile, then we'll go ahead and take a screenshot. So 1, 2, 3, 4, 5, smile. Awesome. Are we good, Priyanka?
Yes, we're good.
Great. I just wanted to say a quick thank you again to our entire audience. I noticed everybody who asked questions today were doctors, but for our students, please feel free in the future. Like, this is a fireside chat. We welcome all questions. We ran out of time today, but this discussion was amazing. And so was the presentation, Dr. Baldwin. Thank you so much. And what was also amazing was the chat tutorials by Dr. Kazaruni and Dr. Katsky and Dr. Stutz. So I encourage everybody to read the chat discussion, which was really good. The Prosper paper would be great for a future discussion to talk about. One of the things about the Prosper study too was that under major complications, they counted lung collapse with acute cardiac arrest, which I'm not sure I would normally do that, because sometimes when you biopsy a nodule, the lung will collapse, and that's very different from the heart stopping, the heart not beating, which usually means something extremely serious. You got to do CPR, the patient's dying. So there are definitely things about that study that are worth discussing in the future. But I'll turn it back to Alex. Just want to say thank you to everybody here. It's been an incredible presentation by Dr. Baldwin, and also the question and answer and discussion.
Wonderful. Thank you so much, Dr. Yang. And just want to say again, a big thank you to Dr. Baldwin. It was a terrific lecture, terrific Q&A, and we just really appreciate your time and the opportunity to learn from you. And a huge thank you to our audience for coming and providing insightful discussion. Everyone should be getting an email at the end of this, at the end of the lecture, just seeing if you guys have any advice on next distinguished lectures or anybody you would like to hear from next. So just please be on the lookout for that. And again, just appreciate everyone's time and for coming today. And I hope everyone has a wonderful rest of their day or wonderful evening for Dr. Baldwin. Thank you.
It's been a great pleasure. Thanks.